This session is palliative therapy in HCC. The chairpersons of this session are Professor Mamun Al-Matab, Head, Interventional Hepatology Division, Bangabandhu Sheikh Mujib Medical University, and Professor Mohammad Mahbub Hussain, former Professor of Hepatology, Rangpur Medical College. We have two speakers in this session, Dr. Chandrasekhar Kormakar, WFSA Pain Medicine Fellow, Anesthetist, Interventional Pain Medicine Specialist, Assistant Professor, BSMMU, and our second speaker is Professor Simon Taylor Robinson, Professor of Translational Medicine, Imperial College London, UK. And our moderator of this session is Dr. Abdullah Al-Qayyum, Registered Department of Hepatology, DMCH. I would like to invite our chairpersons to please come on the stage and take their seats. And now I would like to request Dr. Qayyum to moderate this session.
Thank you, Dr. Narwana. First of all, I would like to request Dr. Chandrasekhar Kormakar, WFSA Pain Medicine Fellow, Anesthetist, Interventional Pain Medicine Specialist, Assistant Professor, BSMU, to deliver his speech regarding pain management in ACC. Dr. Chandrasekhar Kormakar.
Good evening. I am Dr. Chandrasekhar Kormakar, working in the institution BSMMU as Assistant Professor in the Department of Anesthesia, Analgesia and Intensive Care Medicine. My topic is pain management in hepatocellular carcinoma. As we know, pain is a significant concern for most of the cancer patients, and up to 50% of the patients in active treatment and 90% of the patient with advanced disease suffer from severe pain and cancer. Up to 95% of the patient of cancer pain can be managed with appropriate pharmacological therapy, and remaining 5 to 10% of the patient may require interventional therapies. This is WHO analgesic ladder. Most of the cancer patient can be treated following this ladder. Among hepatocellular carcinoma, the codeine and tramadol we usually try to avoid. So the step 2 here is not that much helpful for hepatocellular carcinoma patient, and morphine and fentanyl is the prototype drug for managing hepatocellular carcinoma patient. And step 4, there is another proposed step in WHO analgesic ladder, that would be the interventional approaches for managing intractable cancer pain. The interventions commonly employed in hepatocellular carcinoma and other hepatobiliary malignancies like celiac plexus neurolysis, splanchnic nerve radiofrequency ablation or chemical neurolysis. Those two options are very effective for managing intractable cancer pain arising from upper abdominal malignancies. The celiac plexus outsources parasympathetic, sympathetic and nociceptive fibers. Parasympathetic inputs for the celiac plexus comes from vagus nerve, while sympathetic input is from the greater and lesser splanchnic nerve. Branches from the celiac plexus reach their target organ by forming peripheral plexuses surrounding the branches of the abdominal aorta. The celiac plexus is composed of right and left ganglion located in the aorticorenal anterolateral to the aorta at the level of the celiac trunk. It comprises the celiac, superior mesenteric and aorticorenal ganglia, which forms the dense network of aortic interconnecting nerve fibers. Cochrane review also concluded that celiac plexus block causes fewer adverse effect than opioid. Thus, it is important for patients who are suffering from hepatobiliary malignancies. The pain that originates from the upper abdominal viscera is carried by special visceral afferent fiber that relay through splanchnic nerve and the celiac plexus. The celiac plexus, our target is celiac plexus and splanchnic nerves. Most of the patient we initially try to manage with medication. If medication fails, then we give them choice that they can go for either celiac plexus block or celiac plexus neurolysis, or in advanced stages or patient, those who have anatomical distortion, they can go for splanchnic nerve radiofrequency ablation or splanchnic nerve neurolysis. Celiac plexus neurolysis can be done from anteriorly or from posteriorly. And posterior approach, this is the classic posterior approach where patient is put in under CT scan or under fluoroscope, and L1 vertebra is targeted by a long 5 centimeter long, 5-inch long needle, and about 8 centimeter from midline we go to the L1 spinous process and inferior to the 12th rib. The underlying muscle tissue is also infiltrated with local anesthetic. 20 gauge needle is usually chosen. Each needle is advanced slowly and initially oriented to 45-degree angle towards the midline and about 15-degree angle cephalad using fluoroscopic guidance. Our initial target is L1 vertebral body. Once bony contact is made, the depth of the needle is noted, and the needle is then withdrawn and redirected as a steeper angle, so the needle tip walked off the L1 vertebral body. The left needle is advanced about 2 centimeter beyond the bony contact, and right needle is advanced 4 centimeter post to the vertebral body. After aspiration, we inject local anesthetic and a radio contrast dye to see the dye spread, whether it is appropriate or not. Then if the dye spread is appropriate, then we put local anesthetic, and if patient feels better, then we can inject our neurolytic drug. Celiac plexus can also be blocked and neuralized by CT guidance, and anterior approach can also be chosen. In anterior approach, most of the cases we use ultrasound guidance, and ultrasound guidance we go through the left lobe of the liver, and directly injection can be instilled into the celiac plexus bilaterally. Here is the ultrasound image. Though the precision is quite good, but still some limitations are there. Via ultrasound, intravascular injection can be ruled out precisely. CT scan can also be used in anterior approach. In anterior approach, after putting the needle, we usually inject radio contrast dye, and we see the radio contrast dye spread, whether it is appropriate or not. Then we can instill local anesthetic and our neurolytic agent. Neurolysis can be performed after needle placement with either alcohol or phenol. If the initial test dose is bupivacaine, which leads to pain relief, then neurolytic agent can be instilled using alcohol 50 to 95%, 10 to 20 ml on each side of the, or phenol 5 to 10% phenol, 10 to 15 ml on each side. For splanchnic nerve radiofrequency ablation or neurolysis, usually it is done under fluoroscopic guidance, and our target is D11 vertebral body. Sometimes D12 also chosen along with D11 vertebral body, and in oblique fluoroscopic view, needle is inserted along the body of the D11 vertebra, and needle, after final needle position, we inject radio contrast dye, and needle is placed about at the junction of the posterior 2/3 and anterior 1/3 of the vertebral body. Then radio contrast dye injected, and we follow the dye spread. After appropriate dye spread, we inject local anesthetic, then alcohol or phenol injected. If we want to do it on a radiofrequency ablation, then we do 80 degrees Celsius. At 80 degrees Celsius, 60 to 90 second for 2 lesions on either side. Here is the level of evidence of thoracic splanchnic nerve block. The American Society of Interventional Pain Physician, they reviewed the literature, and they give, it is level 3 evidence is there for managing chronic upper abdominal pain. The Cochrane review concluded 6 studies published from 1993 to 2008. The 6 studies had 358 participants, with 176 receiving a celiac plexus block and 182 a controlled block. The result shows opioid consumption was significantly lower in the celiac plexus group than the control group, and a lower complication rate compared to opioid therapy. In case of bony metastasis, they also advocate bone cementing, and we do bone cementing in bony metastasis to control pain of the patients. Pain is a significant burden for cancer patient, and we should use all the modalities what we have in our hand to control the pain of the patient and give them a comfortable life. Thank you.
Thank you very much, Dr. Chandrasekhar Karmakar, for your nice and elaborate presentation. Now I request Professor Simon Taylor Robinson, Professor of Translational Medicine in Imperial College, London, UK, to deliver his speech regarding terminal care in HCC.
With the permission of the chair. Before Professor Simon Taylor Robinson starts his lecture, I like to say something about him. I know him for last 30 years when he first came to Bangladesh on invitation of Professor Mobin Khan, the Association for the Study of Liver Disease, Bangladesh. And that time I was a very young doctor, even I did not do my post-graduation. So that time he came to Bangladesh. He's a very popular in Bangladesh, probably 6-7 times he has come to Bangladesh. And he's a very well-known professor, and he's a man of great humanity. He used to work in Africa for the betterment of the starved African people, and he used to give them medical services. And now he has retired from active service, but I think he's more active than when he was in active service. I congratulate him and welcome him in Bangladesh because he is our own person. Thank you very much.
Thank you very much for those kind words. I have to say that it's actually my 8th visit to Bangladesh, and I've always felt at home here. People have been so friendly, so nice, and really rather welcoming. So it's always a great pleasure to come and to be able to share some ideas, perhaps. And sometimes you like the ideas, sometimes they're useful, sometimes they're not, who knows. But I hope that these are useful ideas today. So if I can work out how to negotiate everything. Yeah, okay, great. Okay, so I'm going to be talking, the title of this talk was actually terminal care. Terminal care is a word that I think we shouldn't use, mainly because it has a stigma. So end-of-life care has become a more popular term. Equally well, palliative care, which is introduced before that, perhaps also has a stigma amongst doctors, but more particularly amongst patients. And maybe we should reterm palliative care also. So I will be talking about perhaps the ways that we do this. You've heard this morning that it's the commonest primary cancer in the world, that it's the 5th commonest cause of cancer worldwide. And looking up the WHO data from 2020, which is the last available, they say it's the 3rd commonest cause of cancer in Bangladesh. And whatever happens, it's the 3rd leading cause of cancer-related death after lung and GI cancer. About 1 million people a year worldwide get liver cancer, and we're really not very good at treating it, despite all the things that have been talked about thus far in the conference, because about 850,000 people a year die, and those are the 2020 figures. And actually it's probably more than that, because the statistics held by the WHO really aren't that great for many countries, and most things are an underestimate. You know also that any cause of cirrhosis causes liver cancer, but that hepatitis B doesn't need to go through a cirrhotic phase in order to cause the problem. And in countries where they eat moldy peanuts, like in West Africa, then aflatoxin is also a problem too, causing issues that we know about. But actually, in my practice in London, alcohol isn't that common. Everybody thinks it's really common in Europe. It's not, because actually I work in a city which is a global city, and people bring their diseases with them. So in fact there are lots of Bengalis, for example, so hepatitis C and hepatitis B are actually more common in inner city London than alcohol, because people from England don't necessarily live there. So that's just an interesting quirk. The problem is that diagnosis is often too late. And although we like to think about curative treatments, this is the problem that affects people all over the world. And this is one of my African studies. So Professor Salamor was right. I have to mention Africa a little bit. And there you can see a young man who was presenting, aged 27, far too late. And this is unfortunately all too common a problem around the world. And what do we do about it to make people's qualities of life better? Well, you can see that sub-Saharan Africa is a hotspot in red for liver cancer, as is China and Far Eastern countries and places in the Pacific like Papua New Guinea. These are places where hepatitis B is extremely common. But reading the data, it appears that Bangladesh isn't as great a hotspot as that. But nevertheless, there's been a 10% increase in hepatocellular carcinoma in the 2 years from 2018 to 2020, according to the statistics. Maybe some better reporting, who knows? Maybe during the COVID period, they were able to report things a little bit better. I can't tell you that, but nevertheless, it's increasing. It's an increasing problem in Bangladesh and around the world. But sadly, incidence rates, as we've heard, are very much like mortality rates. Ideally, of course, we should have a screening program, and ideally we should pick up tumours early. And there in the bottom diagram you can see a small sub-centimetre tumour picked up with microbubble ultrasound. This is another one of my favourite topics, but actually if you introduce microbubble ultrasound cheaply to ultrasound examinations, it's a cost-effective way of screening. And the Koreans have done that in their various studies and are picking up tumours early. So in a resource-poor country, it's a practicality perhaps in primary care clinics. But unfortunately, things often present late. So if we think that we're going to do active treatment, so things like liver transplantation and chemotherapy, then that's very good. We've picked up the tumour at an earlier stage. But very often we have to think of palliation and end-of-life care. But I would put forwards to you that palliation should actually begin at diagnosis, because it's not something that should be left to the end of life. We need to think about patients' symptoms. Things need to be symptom-driven. We need to think about how the patient's quality of life is. So palliation doesn't mean no active treatment. It actually means patient-focused care. So if we look at the WHO definition for palliative care, it says that we should be improving quality of life of the patients and also their families, who are often distraught at a diagnosis. And it doesn't necessarily have to be a cancer diagnosis, by the way. It's any life-threatening illness. And we should be thinking about relief of suffering, so it should be symptom-driven, and it should be early identification of these issues so that we can assess and treat pain, and also think about psychosocial and spiritual needs, because if the patient is spiritually happy, very often their assessment is much better of pain. So, in the past, the WHO point out that palliative care was a disease-specific issue, but indeed now we need to think about a patient-centered approach. And we should be thinking about dealing with palliative care as early as possible. So, overall goals are to improve quality of life, to think about pain management, as we've heard about in the previous talk, and also to think about symptom management. Given the 360-degree sort of patient focus, we should be giving support to the family and to the various caregivers, so that actually a large majority of care is given in the home, so patients don't wind up dying in hospital, because actually that's not where they want to be. They want to be relieved of pain, relieved of symptoms, and perhaps supported in their final days at home, or indeed, where it exists, in a hospice, which is a specific relief centre for patients who have terminal illnesses. So it's controversial as to when to consider palliative care. Historically, it was always incurable cancer, but actually there's been a frame shift away from thinking of it like that, that it can be considered in any stage of illness, as if it's a terminal illness. But actually, it should not be restricted to people with cancer. So in fact, people who've got end-stage cirrhosis, for example, should be given palliative care that we consider their pain relief, we consider their symptoms. So the hallmark of this is treating patients with dignity, and that we should be honest with our patients about prognosis. Too often, we actually lie to our patients, we evade the issues, we don't tell them the truth, and we often do not have difficult conversations with them, probably because we're not trained to in some ways, and it's difficult to face up to limited mortality, really. But we should take into account the patient's beliefs and wishes, and we should have family involvement in those discussions. And as we heard before from Professor Salimur, that multidisciplinary teams should be involved. So, of course, physicians of various different categories, nurses, and that's really important to consider our nurses, because they are the people who are primarily delivering palliative care. So both primary and secondary care nurses. Physiotherapists, because of course we need to think about symptom relief. Dietitians, very important, because we need to think about nutrition, because people who are adequately nourished live longer, better than any medical issue at this stage. Social workers, perhaps, psychiatrists for mental well-being, but actually more important for that, perhaps, is to think about spiritual and community leaders. So imams in Bangladesh, for the most part. And we need to think about strengthening of patient physician communication, so that actually there is trust. And instead of making decisions for patients, doctors are very good at being paternalistic and making decisions. We should make decisions with the patient rather than for the patient, so that we have a coordination from hospital to hospice to home, and that it's a viable thing to treat people in the home context. How do we assess patients' needs? Well, in the UK, we use a paper and pencil-based test, the Edmonton Symptom Assessment Scale, or ESAS. And we give these out every day to patients on the wards, and they can fill in them themselves. The nurses can help, the family can help. And equally well, if they're coming to outpatients, because they're not necessarily that ill, while they're waiting for the doctor, they can fill out the form, so the doctor actually knows how badly the patient feels. With the ESAS score, there are 8 domains, obviously from 0 to 10, from best to worst, and these domains are pain, activity, so mobility, nausea, which is very important in hepatocellular carcinoma, depression, anxiety, drowsiness, a lack of appetite, and of course a sensation of well-being. It's extremely important to consider these things, but if you use this easy test, you get free information while the patient is waiting for you. And so things to remember that are a real problem for patients who are dying, or indeed patients who are going to have active care, is breathlessness, coughing, dry mouth, nausea and vomiting, constipation sometimes because some of the medications, fever, delirium sometimes because of medication, and excessive secretions as well. So we have to think of all of those issues, and the ESAS score allows us to think about those. It's free information if you hand these out every day on the wards, or indeed in the outpatient clinic. So we had a very elegant talk before about pain, but if one's thinking about standard pain relief rather than thinking about nerve blocks, then we have to think about the best route. Is it oral, subcutaneous? Is it transdermal patches, for example? And also, I would say to you that the use of psychoactive medications is quite important. They're often shied away from, but actually certain psychoactive medications not only make people feel better, but they're antiemetics too. So they stop the vomiting and nausea, and also they make the patient feel better. And why not do that in a situation, in a context of liver cancer? As I said before, nutrition is very important, and the take-home message is that patients should have 1.5 grams of protein per kilogram body weight per day, and that in Western terms is a large steak. It's quite difficult with a vegetarian person to eat enough, but it does mean that they have to have nutritional supplements if they can afford them, if they are purely vegetarian. But we do have to think about appropriate hydration and their quality of life. And as I said before, certain psychoactive medications are good for the nausea and vomiting, apart from making people feel better. Religious and spiritual needs are very important to think about in a 360-degree way. And we really have to have that patient focus, because people feel better if they feel spiritually at ease. And in fact, their perception of pain is less if they are spiritually at ease. And these spiritual needs essentially include feeling capable of loving and feeling loved themselves, actually having forgiveness and forgiving other people, and if you like, in sort of crude terms, deciphering the meaning of life. Our problem is that if you look on the left there, standard palliative care is given at the end of life, when it's too late. Patients have been suffering in the meantime. We should be giving palliation, i.e. symptom-driven care, early on from diagnosis. And this is the sort of model for Western Europe and for the United States. You think about symptom-driven care, patient-focused, right at the early stage when the patient is diagnosed. So when it comes to real end-of-life care, it's not a shock. They're not being referred to new people, and there's no stigma. And it's done very badly around the world. So we as doctors are guilty of not really serving our patients properly because we don't think about symptom-driven care early. We should do that even if patients are having liver transplantation. And that's extremely important. So what are the barriers to palliative care? Well, as you can see, perhaps on the left, we like to think about studies from the literature. There aren't many studies from the literature, so that's a barrier sometimes to some people. You can see also that there are disease factors. We know that the prognosis with the underlying liver disease is variable, so sometimes we're hesitant to introduce palliative care as we think, oh no, the patient's going to survive for much longer, blah, blah, blah. So actually, not necessarily true. We have to think about symptoms. When it comes to clinician factors, well, sometimes we're so busy, there's a lack of time. We don't think about our patients. We see them as a radiology problem. We see them as somebody who needs ablation. We see them as a set of numbers, but we don't necessarily think about their symptoms and how they actually feel. What's it really like to be a person with liver cancer? And also there is a stigma, even amongst physicians, about the whole issue of palliation and indeed later on end-of-life care. And as far as patients are concerned, then there is a problem also with a lack of education. They think, oh my goodness, doctors aren't doing anything for me. In fact, proper palliation should be done at diagnosis. So actually you're thinking about patients' needs all the time. Of course, the literature does allow us to look at perhaps when standard palliation should be given. So, in fact, you might consider the disease stage, you might consider the time after diagnosis, you might consider the prognosis, so less than a year perhaps. You might consider the symptom burden, probably the most important thing, if patients are symptomatic. And there are other things in the literature, but I would put to you symptom-driven and early. A Japanese study from fairly recently looked at 400 gastroenterologists and hepatologists, and they looked at what the barriers were as far as they were concerned to palliative care. In fact, Buddhists tend to do palliative care much better than other people. So Thailand is a very good place for palliative care, and Japan is now a very good place as well. They found, before they introduced an educational study, learning program on palliative care, that the phrase palliative care was basically giving patients a lack of hope. And they also found that the perception was that palliative care only begins when active therapy ends. Both things were a block to its uptake. So the solution probably is you don't use the term palliative care, you use the term supportive care, which in fact was mentioned this morning as best supportive care. So that's what you should use. And the central tenet is it should be patient-focused and symptom-driven. We're there to do that. Maybe as busy active doctors, we can't do it ourselves, but we can train our nurses to do it very well. So the Japanese looked at a study called the Palliative Care Emphasis Program on symptom management and Assessment for Continuous Medical Education. That's a real mouthful, but it's termed PEACE. And what they did was to educate 37,000 Japanese doctors in how to better communicate with their patients, be more aware of symptom management, for example, use of that ESAS score, and actually be better all-round doctors, really. And the educational modules there were 9 of them, but principally pain management, psychosocial care, and better communication skills. And now the Japanese have an exemplary program. This is now part of undergraduate training, how to better communicate, how to think about symptom care rather than necessarily thinking about active treatment separately from that. And you know, to the general medical public, it's crazy that we don't think in the way that we do. Everything should be together. So, when to introduce palliative care? Well, you can see at the top there, maybe I've got a thing here. Yes, okay. So, it's when there is emotional and spiritual distress. Also, when patients perhaps have refused active treatment, but when there are uncontrolled physical symptoms too. So, that's really important. But what are the barriers to palliative care? Well, you can see quite a few of them there. So there's the fact that, that doctors overestimate the life expectancy. They're focusing on liver-saving procedures like this morning, forgetting patient symptoms. There's also a misconception of palliative care, I would say. And they're not very good at, as we've pointed out, at end-of-life discussions. So all of these things are issues that delay symptom-driven management. And of course, we're not necessarily very good at communicating bad news. Japanese have improved it, and I commend it to you. What are the barriers to patients? Well, actually, to put it in a nutshell, there is a lack of education and a lack of honesty with our patients as to what the real situation is. And many patients in many countries actually don't know they got cancer because the family don't want to tell them. We shouldn't be like that. We should be honest. In Arab countries, there isn't a word for cancer because it's a stigma. You can't talk about it. So patients die in a complete painful way without having the benefit of symptom-driven treatment. We learnt very well and in a very erudite sort of way about liver transplantation. But this is a model from the United States, which I don't expect you to look at completely. But what you can see at the top there is that palliative care, symptom-driven management, is actually part of the liver transplantation team. So great, you have all those fantastic doctors doing active treatment, but you're also thinking about symptom-driven care at the highest level, even with the highest and most expensive active treatment for liver cancer. And it's a continuum right the way through to terminal care. So there is a continuum from symptom-driven palliative care through to end-of-life care or terminal care, as I was given the name for the talk. So, I believe in being short and succinct and perhaps not going over time. Just in summary, palliative care should be introduced early. This is really a stigma for many doctors' cases because they're too busy and we're going to save the patient. Yeah, but we forget about the symptoms. So there should be a 360-degree patient-centered focus. As I say, absolutely about symptoms. Think about the ESAS score, easily downloadable, available on the app for the younger people. You can look at the symptoms every day, patient can fill it out, and you know what's bothering the patient and you can deal with it. Very useful for nurses if you're going to use nurses for symptom-driven palliation. And it's a continuation to end-of-life care. And Of course, the team should be multidisciplinary, but do not forget your religious and spiritual leaders. Very important for well-being for most patients. And I think we should consider reterming palliation supportive care. It doesn't have that stigma that that actually palliation or end of life or terminal care has. They all have supportive care. And to the general public, that's what doctors should really be doing. Because in fact, if you take questionnaires of patients, they only want pain relief, they only want to get rid of the problems like constipation. They don't care what other things are happening. Doctors can deal with it, but they actually want to feel better, better quality of life. So I would commend to you for Bangladesh, because obviously it's a resource-poor country and it's an interesting thing to look at the Marie Curie cancer care. This is actually a charity, and they run free care for patients. They don't actually have to be patients with cancer, in fact. They are terminal care diagnoses, so indeed people with end-stage cirrhosis. And what they do is to offer 8-hour care to families at home, so that actually families can take a break if there is a problem, and that they themselves can have a rest from caring for their critically sick relative who wants to die at home. It's a very good model, and they have been able to train nurses to be out in the community, very low cost, to be able to improve patients' qualities of life at home. So really quite important to think about. And I would like to thank Professor Marsha Morgan and Dr. Heather Lewis, who gave me some useful information about the sort of latest trends in palliative or supportive care. And two of the principal references are down there. And I would like to say that I'm very pleased and very honoured to have had this invitation to come to speak. It's always a great honour to do so. My Bengali is limited. I know things like Amar Sona Bangla, so my golden Bengal, and Bangladesh Zindabad, so long live Bangladesh.
Thank you very much, Professor Simon Taylor Robinson, sir, for his excellent deliberation regarding terminal care in HCC. Now, this is time for question and answer session. Dear learned audience, if you have any question, please ask to our honorable speakers.
I have a question to Professor Simon Taylor Robinson. Thank you very much for your very elaborate and very excellent lecture. I want to learn from you a very practical thing. As you have already mentioned that we must be very truth to the terminally sick and terminally ill patient who is suffering from liver cancer. Not only liver cancer, other cancer also. But as you know, you usually expose this news to the patient. But in my country, I think you have already mentioned this, when the relatives brings patient to us, some of the relatives enter into our chamber first and they say, don't tell anything to the patient, don't tell anything to the patient, in this way. But that becomes very difficult. But actually, I usually give them a bad word and say it is my job how to tell the patient and up to what news we should give to the patient. In your country, how do you convey this very bad news or news of a cancer to the very sick patient? Thank
Somebody
you.
will have to come up here, I think. This is not working. Yes, you're 100% right, but actually we believe that our contract is with the patient, not with the family. And very often there are conflicting interests with the family. And there are lots of reasons why they don't want the person to know. And very often very complex reasons why that is. It's not necessarily for the patient's well-being. And actually, if it's done in a supportive way, and you have a supportive palliative care system, then actually they are supported psychologically, spiritually, and everything else with that diagnosis. But in fact, they've found out in some studies that people who know about their diagnosis do actually better than people who don't. And that may be something to think about. And you can tell patients that actually, if you don't tell the person, they may die earlier. And actually that's important because you can't have the appropriate supportive care. So studies have well shown, palliative care studies, that honesty on diagnosis is primarily important, even if the families don't want that. So you have to have a difficult discussion with the families, essentially, to point out, well, if you want the patient to live longer, it's important for them to know about that, because one isn't going to alter the prognosis by them not knowing. Yeah. I've clearly stunned everybody into silence, I think.
Thank you, sir. Now this is the time for comment on this session. Professor Muhammad Mahbub Hossain sir, I would like to request him to comment on this session.
Bismillahirrahmanirrahim. Thank you, my mentor, my teacher, my guardian, Professor Selimur Rahman sir, for arranging such a good and informative seminar, especially for the liver specialists and those who are practicing in different parts of Bangladesh. It's really a good and informative seminar. I want to thank Dr. Kormokar. We are very disgusting condition. We really faces very disgusting condition regarding the pain in ACC, and we are helpless at the time. What thing we can do? But you are making a lighthouse by celiac plexus blocking system, though it is not available in different parts of Bangladesh. But it gives us a message by which we can give more comfortable to the patient. And secondly, the last speaker, Professor Robinson, he's from London. After a long effort, you have come here to glorify this session, and we are very happy to get you in this auspicious day and auspicious seminar. You told much about the supportive care. You are just, that is very amazing that we are going to change the terminal care, palliative care. Now it is supportive care. Supportive care is more comfortable to me, because when we are talking about the terminal care to the patient says, yes, I am gone. But if we say, yes, you are getting supportive care from me, he is hopeful. I think so. Now I want to speak in Bangla. দুই কথা ছাড়া একটু বলবো, না বললে হচ্ছে না। আমি মাহবুব হোসেন, আমি রংপুর এলাকায় চাকরি করি। এখানে আমাদের বাংলাদেশের যারা আছে রংপুরকে চেনে, নর্দার্ন জোন অফ বাংলাদেশ। এখানকার মানুষের আর্থিক অবস্থা তুলনামূলকভাবে বাংলাদেশের অন্যান্য এলাকার থেকে একটু খারাপ বলা যায়, দুর্বল। তো এই দুর্বল মানুষদের নিয়ে আমার চলাফেরা। যখন আমি কাউকে ডায়াগনোসিস করি লিভার ক্যান্সার, তো ছেলে হলে কান্নাকাটি শুরু করে, মেয়ে হলে অজ্ঞান হয়ে পড়ে যায় যে আমার বাবার কি হবে, আমার মায়ের কি হবে। তো এইভাবেই শুরু হয়ে যায় এই লিভার ক্যান্সার, হেপাটোসেলুলার কার্সিনোমার ট্রিটমেন্ট। বেসিক্যালি আমরা কি করতে পারি? বেসিক্যালি আমরা তো আজকে ডে লং আমরা এখানে করলাম, এখানে টেস্ট করলাম, এখানে পার্শিয়াল লিভার ট্রান্সপ্লান্ট করলাম, কত কি করলাম, কিন্তু আলটিমেটলি কি পেরিফেরিতে এগুলো করা সম্ভব? এগুলো করা সম্ভব হয় না। তা আমি যেগুলো করতাম, প্রফেসর সাইমন সেইগুলোকেই সাপোর্ট করে গেল। আমি যেটা আগে রুগীকে একটু সাহস দেই, আপনার কিছু হয় নাই, কিছুদিন বেঁচে থাকবেন, ভয় নাই। রুগীর আত্মীয় স্বজনকে বলি স্পিরিচুয়াল অ্যান্ড রিলিজিয়াস কিছু উপদেশ দেই, যেটা শুনতে খারাপ লাগে কিন্তু বলতে হয় তাই। আল্লাহর মাল আল্লাহ নিয়ে যাবে, আপনি প্রস্তুত হন। এরকম আমার বেশিরভাগ কলিগরাই, আমার টিচাররাও এরকম বলে, এছাড়া বলার কোনো উপায় থাকে না। ডক্টর কর্মকার সুন্দর একটা স্টেপ দেখাইছে, কিন্তু ওই স্টেপটা আর একটু বেশি বললে ভালো হইতো। প্রথমে কিছু অ্যাডজুভেন্ট থাকে, তারপরে কিছু পেনকিলার থাকে, তারপর চলে আসে অপিওয়েড। অপিওয়েড নিয়ে অনেক সমস্যা আছে, আর অপিওয়েড পাওয়া যায় না পেরিফেরিতে। তখন আমাদের কি করতে হয়? আমরা তো আসলে রুগীকে ভালো চিকিৎসা দিতে পারি না। তো আপনি স্যার উদ্যোগী হয়ে এগিয়ে আসছেন। এখানে বিএসএল সিটিআর, বাংলাদেশ সোসাইটি অফ লিভার ক্যান্সার অ্যান্ড ট্রিটমেন্ট রিসার্চ, স্যার এখানে একটা কিছু করবেন, আমরা যেন দূর দূরান্ত থেকে রুগীকে লাস্ট টার্মিনাল হিসাবে পাঠাই দিতে পারি, যে কিছু না হলেও ওখানে আপনি কিছু চিকিৎসা পাবেন। আই এম সরি টু স্পিক ইন বাংলা, অ্যান্ড মাই teachers, my audience are happy to, I think, understand the real gist, the practical problem what we face in distant part of Bangladesh, not in the, sorry? Okay, thank you, sir.
I heard the professor talking about opioids, and I avoided that subject because sometimes it's difficult, and I thought that perhaps the previous talk was going to deal with it. But one thing we should not do is to fail to give opioids to our patients if they need them. You know, there is this idea that in liver disease we should withhold them because it may cause hepatic encephalopathy. Actually, if patients have a liver cancer and limited prognosis, if they need pain relief and they are not able to have sophisticated techniques like celiac plexus blocks and so on, you know, we need to use traditional treatments. And actually, you know, this also helps in well-being. Patients survive better if they are treated properly with their symptoms. So actually a take-home message is not to forget opioids, because, you know, they are often held as a stigma, but actually if patients need them, we have a duty to give them.
Thank you very much for patient sharing, and with these few words I want to conclude this session. Thank you, sir. Thank you, Professor. Thank you, Doctor. Sir. Memento. Now, this is the time to give memento, sir. Excuse me, sir. Please, sir.
I would like to request Professor Selimur Rahman, sir, to come to the stage. And I would like to request Professor Mahmoud, sir, to give memento to our honorable foreign speaker, Professor Simon Taylor Robinson.
Now it is our last session for today, and we have 4 speakers in this session. Our first speaker is Dr. Horidas Shaha Pratap, Associate Professor and Head of Department of Surgical Gastroenterology and Unit Head of Hepatobiliary and Pancreatic Surgery, Sheikh Russell National Gastroenterology Institute and Hospital, Dhaka. And he will speak on clinical outcome of the liver resection single center experience. And there are 3 cases in this session, and the speakers are Professor Farooq Ahmed, Professor and Head of Department of Hepatology, Dhaka Medical College Hospital, Dr. Mohammad Fazul Karim, Associate Professor and Head of Department of Hepatology, Sir Solimullah Medical College, and Dr. Ahmed Sarwar Murshid, Interventional Oncologist, Anwar Khan Modern Hospital, Dhaka. This session will be chaired by Professor Selimur Rahman, President, Bangladesh Society for Liver Cancer Treatment and Research, and Professor Prajesh Kumar Roy, former Professor of Gastroenterology, BSMMU, Senior Vice President, Bangladesh Gastroenterology Society. And the moderator of this session is Dr. Mahmudul Haq, IMO, Hepatology Department, Dhaka Medical College Hospital. Now I would like to invite all our speakers and chairpersons, sir, please come on the stage and take their seats. And now I would like to invite Dr. Mahmudul Haq to moderate the session.
Assalamu alaikum and good afternoon. Now, Dr. Horidas Shaha Pratap, Associate Professor and Head, Department of Surgical Gastroenterology and Unit Head of Hepatobiliary and Pancreatic Surgery, Sheikh Russell Gastro Liver Hospital, Dhaka. I would like to request sir to say on his topic, clinical outcome of liver resection, single center experience.
Thank you very much, and I am very grateful to the society as my presentation was on morning session, but I was in busy for a team from the Nebraska, USA visited in my hospital for liver transplantation issue. For the reason I was engaged that this time. I am Dr. Hridhar Pratap, an associate professor and unit head of the hepatobiliary and pancreatic surgery, Sheikh Russell National Gastroliver Institute and Hospital. And my today talks about the clinical outcome of liver resection. This is my single center experience. There is the liver resection is indicated for various reasons, like there are the various benign condition and malignant condition. In case of the malignant condition, the hepatocellular carcinoma, intrahepatic cholangiocarcinoma, gallbladder carcinoma, and some benign condition we indicated for liver transplantation, like that of the hepaticolithiasis and other causes also needed for liver resection. And liver resection is challenging surgery due to its high mortality and morbidity. And outcomes after liver resection is significantly improved in current decades due to improvement of the various techniques and the understanding of the various anatomy and all the relevant investigation regarding the diagnosis and outcome of the patients. And for the reason, recently the mortality is markedly reduced in post-resection of the hepatic tumor or other causes of hepatic resection. And there is the number of the factors that are contributed to the improvement of the surgical outcome, that included the innovation of surgical techniques and novel devices for the bloodless surgery and the parenchymal transection, and preoperative portal vein embolization for the contralateral lobe hypertrophy and advanced anesthetic management. Of course, that is the enhanced postoperative care by which we can reduce the postoperative and mortality and morbidity of the patient after liver resection. And despite the improvement of patient survival, hepatic resection still associated with a significantly high morbidity rate rather than mortality. Therefore, we decided to review the outcome of the hepatic resection. And current study was aimed to determine the spectrum of the presentation, magnitude of the liver resection, and outcome including blood loss, morbidity, mortality in patients undergoing liver resection in Sheikh Russell National Gastroliver Institute and Hospital, Dhaka. Methods, this is the retrospective study which are conducted in the hepatobiliary surgery unit of the Sheikh Russell Gastroliver Institute and Hospital. There is the January 2022, October 2022. All the patients included here, irrespective of type of liver resection. And the indications of liver resections at that period, there is the ACC, number of the patient is 15, Klaskin tumor 4, gallbladder malignancy 35, hepaticolithiasis 26, bile duct injury, hemangioma, and hepatic adenoma. And the total patients number is 110. And all the patients had a triphasic CT scan and or MRI to evaluate the pathology of the liver and assess the resectability of the tumor. At the same time, we have to do the CT volumetry and 3D reconstruction for the angiogram of the liver tumor, particularly in case of cirrhotic liver and Klaskin tumor. Assessment of the functional reserve of the liver was assessed by CTP score. This is the liver resection. We did the right hepatectomy. This gentleman in the picture is Takasaki. Takasaki, who invented the extrafacial approach for the liver resection. We perform the right hepatectomy by 3 approaches. That is one of the Gleason and Perical approach. Another one is anterior approach, and and last one is conventional approach. And this is the right hepatectomy specimen. You can see the hilar dissection. This is the conventional method, left side of this slide. And middle of the slide, you can see very nicely about the ischemic line of the right liver. And after that, you have to see the resected surface of the right liver. You can see clearly the diaphragm behind of it. This is the specimen of the right hepatectomy. At the same time, you can see picture of the hepatic ischemic line. You can see it in the left side of the picture. And the same picture is that. This is the right hepatectomy. These also we have done the some causes a right posterior sectionectomy. If the tumor is located extreme right of the segment, we can go for right posterior sectionectomy. This is also a right posterior sectionectomy, and later on we have to discuss about the left hepatectomy. We did left hepatectomy by same manner like that of the right hepatectomy, like that of the anterior approach, Gleason and pedicle approach, or conventional approach. And we perform the hepatectomy by all control of the vessel, like that of the inflow control, outflow control, and later we have to consider the parenchymal dissection. This is clearly, you can see the hilar structure. Separately you can identify all the structure in the hilar region. And after that we have to create an ischemic line in the Cantis line, that is the involvement of the left whole of the liver. And after resection of the liver, the cut surface. And the liver resection, we found a lot of patients in the carcinoma gallbladder. In the relation, we have to do extended cholecystectomy, or we have to do resection of the segment 4B or 5. And this is the extended cholecystectomy. Extended cholecystectomy that includes the resection of the liver as well as lymph node dissection, hilar lymph node dissection. And the extended cholecystectomy and lymphadenectomy. After that, all the structure is denuded from the fatty tissue, including the lymph node. And sometimes we have the gallbladder carcinoma that may liver invasion and biliary invasion. That time is a troublesome condition for the surgeons for doing surgery. That time we have to do extensive surgery, like that of the resection of the segment 4B, 5. At the same time, we have to resect the extrahepatic biliary tree, draining lymph node, and we have to reconstruct it by hepatic zozonostomy. This is the variable we used here is in this study, that is the demographic of the patient, indication of the surgery, types of the hepatic resection, and duration of the surgery, estimated blood loss, and concomitant procedure also with the hepatic resection. The postoperative variables include surgical complications, including wound infection, bile leak, ascites, hemorrhage, and 30-day mortality. And we mentioned about in my study, 110 patients included here, and out of which male is 45 and female is 65. Mean age of the patient is in and around 45 years. And 74 patients having some other mortality also. And 8 patients are having a chronic liver disease, that is the cirrhosis of the liver. And this is the demographic. I will skip the slide. Demographic. 54 patients undergone resection due to malignant diseases, and including the hepatocellular carcinoma, gallbladder carcinoma, and Klatskin tumor. In case of Klatskin tumor, we do right hepatectomy or left hepatectomy and excision of the extrahepatic biliary tree, lymphatic dissection, and reconstruction by a hepatic zozonostomy. We didn't still started dilting the portal vein. If the portal vein is thrombus or emboli, thrombus in the portal vein, we are trying to do it in the coming future. At the same time of the liver resection, do the portal vein dissection and reconstruction. And this is the type of resection already mentioned here. And the liver resection of the benign disease. Most of the benign disease we dissected. There is a hepatic adenoma, FNAs, or hemangioma, or a most common case is hepaticolithiasis. And liver resection for the malignant diseases like HCC, right hepatectomy. My study period was 1 year, that is 2022, 2022. And later on we passed 8 or 9 months. Already we did a lot of left hepatectomy, a lot of right hepatectomy already. And we did the right hepatectomy of HCC, ACC for left hepatectomy, right posterior sectionectomy, non-anatomical resection also, and debulking of the tumor, and extended cholecystectomy, and excision of the segment 4 that I also already mentioned, segment 5, and excision of the extrahepatic biliary and biliary reconstruction. And most commonly performed liver resection is extended cholecystectomy, that is gallbladder carcinoma, for gallbladder carcinoma. And 7 patients who had gallbladder carcinoma need excision of the segment 4B and 5. At that time, we need biliary reconstruction by hepatic angiostomy. Lethal segmentectomy is most performed operation due to left-sided hepaticolithiasis. And we perform 8 right posterior sectionectomy, right hepatectomy, and 1 patient develops post-operative ascites due to pre-existing chronic liver disease, that is cirrhosis of the liver. And with the, there is the surgical results regarding the duration of the operation is 170 minutes plus minus 138 minutes, and estimated blood loss is also in relation to the paper, international standard paper. And intraoperative transfusion, we need intraoperative transfusion more than 2 to average 2 unit blood transfusion, and 4 patient, only 4 patient need our ICU support. The mean duration of the surgery already I mentioned here, and the outcomes of the liver resection, this is the wound infection, biliary leakage, hemorrhage, ascites, because we know that the liver resection after ACC or sometimes Klaskin tumor, we are very scary about the development of the post resection liver decompensation. And postoperative morbidity was 24 patients, that is the 21.82%, and surgical site infection is 13 patients, which is significantly higher in benign disease in case of hepaticolithiasis. And postoperative biliary leak and ascites developed 4 patients, and postoperative ascites was developed in patients who had a previous chronic liver disease, and that is 2 patients. There is 1.82% mortality who underwent debulking surgery for ACC. That means on the whole series, among 110 patients, I have a mortality 1.2%, 1.82%. The discussion regarding the hepatic resection has progressed a high-risk surgery to an established therapeutic modality with indication ranging from the primary hepatobiliary malignancy to metastatic diseases. And progressive improvement in the mortality rates over the years have evolved this procedure into the safe therapeutical option for the careful selected patients. We had overall morbidity rate is 21.82%, and the main cause of the morbidity is wound infection, bile leak, postoperative ascites, and postoperative hemorrhage. This morbidities prolong the postoperative recovery period, but were successfully managed conservatively. 2 patients need a relaparotomy, one for bile leak and one for postoperative hemorrhage. Our 30 days mortality rate was 1.82%, was comparable to different published data. There is the 1.82% mortality. This is very encouraging. And the proper technique and some devices are necessary for the safe hepatic resection. That is the understanding of there is very important thing is the understanding of appropriate technique for the vascular control and parenchymal resection. And preoperative good quality imaging, this is very much also important because preoperative CT scan and preoperative MRI can detect you the diagnosis as well as your plan of treatment, plan of surgery. And retractor, there are so many retractor for the retraction of the rib cage also. That is very important for the operation, and COSA for the parenchymal transection. Various energy devices that is necessary for the liver resection, that is the argon beam coagulator, ligature, and duplex ultrasonogram, intraoperative ultrasonogram, CT volumetry, CT angiogram, MR angiogram, staples, and sometimes we need the bridging therapy like that of the RFA, microwave, or TASE, After that, we can do liver resection. And conclusion is that in past, liver resection was a very complicated surgery with high morbidity and mortality. But nowadays, preoperative evaluation, preoperative techniques with advanced surgical devices and postoperative care can reduce the mortality, morbidity with a remarkable outcome. And with these few words, thank you very much for your patient sharing.
Thank you, sir, for your nice presentation. Now we have 3 clinical cases to be discussed. First case will be presented by Professor Farooq Ahmed, Professor and Head Department of Hepatology, Dhaka Medical College Hospital. I would like to request sir to present the case.
কিছু টেকনিক্যাল অসুবিধা হচ্ছে, আমাদের স্পিকার তার ল্যাপটপ থেকে দেখে দেখে বলবেন, এই কিছুক্ষণের মধ্যে আশা করি আমরা আমাদের প্রজেক্টরে চলে আসবে।
Assalamu alaikum, respected chairpersons, Learned audience, ladies and gentlemen, good evening. Sorry for the inconvenience at the late this session. This is Farooq Ahmed, Professor of Hepatology, Dhaka Medical College Hospital. I will just present in short a case summary of a patient of chronic liver disease who has developed some grave complications, you will see. Mr. HK, 67 years old, diabetic, hypertensive, retired service holder hailing from Chatpur. He was previously diagnosed as compensated cirrhosis of liver for last 2 years and was on regular follow-up. He presented in December 2022 with upper abdominal pain and discomfort for last 3 months. The pain was moderate in intensity, not related to food or posture, and had no radiation. For the last 1 month, he also complained of marked loss of appetite, weight loss, and extreme weakness. His bowel habit is normal. He is also experiencing a mass in the upper abdomen, which is painless but slowly increasing in size. There is no history of jaundice, ascites, hematemesis, melena, and no episodes of altered loss of level of consciousness. So in examination, you see that patient is mildly anemic, he was not icteric, and there was leukonuria. The abdomen is not distended, flanks are not full, umbilicus is inverted, liver is palpable, it is 4 cm, mildly tender, hard in consistency with irregular surface and margin. Spleen not palpable, testicular atrophy was present, and shifting dullness was absent. So with this clinical picture, we went for investigations. I am not showing the other liver function tests along with ultrasonogram examinations. I am just showing the picture of the contrast renal CT scan, which was done after his admission. So this CT scan finding was consistent with chronic liver disease with multiple nodular swells, mainly in the right lobe, involved in the segment 6 and 7, and some lesions were also in left lobe. So the possibilities were multifocal ACC, dysplastic nodules, and the portal vein was dilated, but there was no evidence of any thrombus in the portal vein main trunk or any branches. The patient with this, based on clinical presentation, biochemical tests, ultrasonograph SBS, tumor markers. So as I am not showing that there were viral markers were negative, SBSAG, anti-CV, anti-SBC total was negative, and biochemical tests including his bilirubin, SGPT, alphos was with the normal limits. He was undergone cytopathological examinations, and he was diagnosed as compensated NASH cirrhosis of liver with hepatocellular carcinoma. He was in child score A, BCLC stage B with a performance status of 0. With these findings, the patient was in abroad, and they considered to do radiofrequency ablation. It was done in abroad, and following 1 episode of RFA, there was no significant reduction of alpha-fetoprotein, and actually alpha-fetoprotein was gradually increasing, and also there was increase in liver size with marked anorexia. Still, patient is in child age state, and what are the treatment modalities that can be taken in this patient? If anyone from the audience can give valuable opinion in this regard. With this picture, though the summary was too short, so with this picture, what should be the treatment modalities at this moment? The patient is in child A, and he had undergone RFA 1 month back. Well, what we did, the test was done on 18 December. He was followed up after 1 month, which revealed much improvement of his symptoms, along with slight decrease of alpha-fetoprotein. And financial constraints was there. So there was limited options of repeated tests or use of conventional immune therapy, which was a good option for this patient at this stage. This was the picture of transarterial chemoembolization. This was the first case of transarterial chemoembolization in Dhaka Medical College Hospital under hepatology department. We used the neuro surgery cath lab to do the test. So after test, after 1.5 months, Alpha-fetoprotein was declined. Patient condition was stable at the time. Follow-up triphasic CT scan of HBS reveals multifocal ACC still there. And the patient was put on lenvatinib along with other medication. And recently the patient developed some features of hepatic encephalopathy, and he is being treated conservatively. So this was the TACE team at the time. And Dr. Fazal Karim from Midford Hospital, he was also with us because he was an expert in this regard. So this was the case, it's a case summary. If anyone has some opinion or any comment regarding the case. Well, thank you all.
Thank you, Professor Farooq Ahmed sir, for your nice presentation and great work at Dhaka Medical College Hospital. Now, case 2 will be presented by Dr. Mohammad Fazal Karim sir, Associate Professor and Head Department of Hepatology, Sir Salimullah Medical College Hospital. I would like to request sir to present the case.
Slide change. Number slide 2. এটাতে হবে না আচ্ছা কোনটা দিয়ে স্লাইড Thank you very much, honorable chairpersons, my learned audience. Thank you very much for giving me opportunity to present my case. Now, my case is a 35-year-old male who presented to us. He was a Muslim small-scale businessman, that is a taxi driver by profession, hailing from Keranganj, Dhaka. He presented to us on May 2021 with abdominal painfulness. Further, with investigations, clinical examination and investigations, he was diagnosed as a case of hepatocellular carcinoma with etiology of hepatitis B, and the patient was in BCLC stage A with performance status of 0. And his relevant his CBC was normal, LFT was normal, apart from albumin level, which was 2.5 milligram gram per deciliter, and prothrombin time was normal. Not functioning. That's not functioning. That's anti-HBC total was positive, DNA was negative, and there was a swell in liver which was 10 into 8.5 centimeter right lobe of liver, and alpha fetoprotein level was 50,000 and fibroscan value was 18.6. With this we had a diagnosis of a hepatocellular carcinoma. It's not a smooth. না এইদিকে যায় এটা তো স্পষ্ট নেই না না সেটা ঠিক আছে with CT scan we had a bit larger lesion 15 into 12 centimeter involving segment 6, 7, 8 with portal vein dilated but without having any thrombus, and we had FNA which revealed a carcinoma of positive for malignancy, and the diagnosis of hepatocellular carcinoma was made, and this is the picture of the patient at the initial diagnosis. At this patient, as the patient was having a tumor of more than 5 centimeter, and when in compensated state, we have a diagnosis of BSLC stage A with performance status of 0, and we planned a treatment with radiofrequency ablation with tyrosine kinase inhibitor 8 milligram per day. With first session of RFA, there is significant reduction of the tumor size as well as the alpha fetoprotein level, and this is the picture after first RFA. Then we had second RFA after 16 weeks, and at that time there is further reduction in the alpha fetoprotein level as well as the tumor size. This is second RFA, and the patient has a very good lifespan for 16 months. At that time, patient has no significant problem and had no adverse effect of the drugs, tyrosine kinase inhibitor, lenvatinib. But after 15 months, there have been follow-up. The patient has suddenly increase in the tumor size, also increase in the alpha fetoprotein level. At that time, we did further RFA, which led to further reduction in the tumor size and also reduction in the alpha fetoprotein level. But this is the third RFA. After that, we suddenly noticed a palpable lymph node in the cervical region, and FNA of that liver, the FNA of the lymph node revealed metastatic poorly differentiated carcinoma from 2 labs and 1 denoting metastatic carcinoma. As there was adenocarcinoma report, we had extensive search for tumor elsewhere in the body, and on the basis of this search, we did CT scan, CA99, CA, chest X-ray, and colonoscopy. And after that, we did also liver function test, and also we did immunohistochemistry. From the immunohistochemistry, we get a PAR1 positive and glypican positive. On the basis of this, we had a diagnosis of metastatic hepatocellular carcinoma from the lymph node, of the lymph node. At that time, patient was in BCLC stage 3 with performance 0. So, systemic therapy or immunotherapy was planned. But the patient was unable to bear the expenses, so conventional immunotherapy of atezolizumab and bevacizumab was not offered, rather nivolumab combined with lenvatinib was planned. And patient was offered nivolumab 100 milligram per dose at 3 months interval. After first injection, the patient has a very good tolerance with only neck pain and back pain. But after that was dealt with by baclofen, but the patient had no further complications. After that, the patient had sudden appearance of jaundice, ascites, and also shortness of breath. At that time, we had a diagnosis of ACLF, and patient was managed conservatively. And this patient was doing well, patient was doing well and was a bit better, but after that, after 7 days, the patient developed sudden respiratory deterioration and urinary retention, which was dealt with conservatively. And as the patient developed respiratory distress, we tried to transfer the patient to ICU, but there was no seat vacant at that time, and the patient died with this complication. So from, you see from this is the sequence of treatment we have given. RFA, then lenvatinib, then RFA, then lenvatinib. This combination was continued. This combination is proved to be very much tolerable to the patient. And after that, we had nivolumab. So in conclusion, I like to say that there is a role of immune checkpoint inhibitor in the treatment of non-resectable hepatocellular carcinoma, while we have to keep an eye on early detection and management of these immune checkpoint inhibitors related to hepatitis toxicity, so that we can mitigate this problem at earlier. With this, I like to conclude. Thank you.
Thank you, sir, for your nice presentation and for your tremendous effort for the patient. Now, case 3 will be presented by Dr. Ahmed Sarwar Murshid sir, interventional oncologist, Anwar Khan Modern Hospital, Dhaka. I would like to invite sir to present the case.
ল্যাপটপ থেকে করা যাবে না তাহলে তো বিপদ হয়েছে With the permission of our distinguished chairman, I'd like to commence my speech on a very interesting case. It is a BCLC B1 HCC case. She is a 49 years old female, came to see us on August 21st, 2021 with complaints of loss of appetite, gradual weight loss, and generalized weakness and mild pain in the right hypochondria. These are typical features of HCC, early HCC. There is a past history of SBS AG positive. On general examination, we found anemia, otherwise no abnormality detected. Ultrasonogram showed a swell in the liver, no ascites. Auto mean time was 13 seconds, INR was 1.3, serum albumin was 3.5 milligram per DL, and serum bilirubin was 0.9 milligram per DL. That is a child A cirrhosis. And alpha fetoprotein was 400. When you have 400 alpha fetoprotein level 400, you mean that you may have good prognosis if you can treat the patient completely. So then we went for a contrast-enhanced triphasic CT scan, which showed quite a big tumor that is around 7 into 6.5 into 5.5 centimeter in 3 dimension in segment 8. And it took up dyes in arterial phases and it washed away in early venous phases. And there was no thrombus in the portal vein. That is very also important. If there is thrombus in the portal vein, that means that HCC is very advanced, but it is free of thrombus. And FNC done, there's a routine, and the disease was staged as BCLC B1. So what we thought about the treatment plan is first is transplantation, but we could not do it because it is out of Milan criteria. Number two, we thought about the surgery, but the portal venous pressure was high, so surgeon refused to do surgery in this case because of chance of bleeding and liver failure. Number three, the test. We thought about the test. According to the BCLC, it is the recommended treatment for the BCLC B1 tumors. And then we can also think about the test followed by microwave ablation. And this is the best choice of treatment in this stages of the liver tumor. A lot of studies showed that when we combine TACE and microwave together, the significant increase in the survival benefit and tumor response. And the alternative is microwave ablation alone. Why the selection of, why we think about the TACE followed by microwave ablation? Because you know the overall survival in tumor size 5 to 8 centimeter, 1 year survival is as high as 77% in TACE group and 86% in the microwave ablation group. While you combine these two, it increased to up to 93%. You can see that it's quite high. And in 5 years, you can see individually TACE 3-5 year survival is only 21%. And with microwave ablation, you can get only 13% survival. But when you combine these two, you see the significant increase in the long-term survival of 5 to 8 centimeter group of people. So nowadays, the interventional oncologists or radiologists, they combine these two to treat this kind of big tumors. Not only that, even in bigger tumor, in 10 centimeter tumor, another interesting study that is also published in International Journal for Hypothermia, when we found that you can control tumor as big as 10 centimeter with TACE, with 3 year survival, 1 year survival is 59 and 3 year survival is 11%. But when you combine TACE with microwave, 1 year survival will increase up to 85% in giant tumors. And 3 year survival is as high as 32%. It is a remarkable achievement even in the giant tumor control. So in this particular patient, she refused to go for TACE because at that time she thought that it is quite an expensive treatment. So she gave us option to do microwave ablation. Microwave ablation is also a good choice for BCLC B1 cases, because there was a time we could only ablate a 4 centimeter tumor with microwave ablation system. But with the advancement of the technology and introduction of the cool tips in the antenna and new treatment strategies help us to expand the ablation zone as big as 9.5 centimeter. So nowadays with microwave ablation, we can ablate ablate tumors as big as 9.5 centimeter. Microwave ablation is now regarded as the curative treatment for the very early diseases, BCLC diseases. Also, also cure the tumor as big as 4 centimeter. Microwave ablation is also a palliative therapy for the advanced cases if the other treatment options fails or we cannot go for the other treatment with other modalities. Okay, then next one is a comprehensive study recently published by the Italian doctor. They have done a good comparison studies. You can see they can ablate 100%, they can ablate tumor completely in 100% cases when the tumor size was 1.5 to 3.5 centimeter. Not only that, they can also achieve complete ablation in 100% cases with when the tumor size is as big as 5 centimeter. But in that case, they had to use multiple session. And even in case of 8 centimeter tumors, they have achieved complete ablation in 92% cases. So you can see with advancements of the technology, with microwave ablation, we can successfully completely ablate the tumors as big as 8 centimeter with good overall survival rate. You can see in small tumors, 1 year survival is 89%, and 1 year survival is 86% in 8 centimeter tumors. This is quite high nowadays. But with microwave ablation, we cannot achieve long-term survival benefit in bigger tumors. So here, TACE play a good role. When you combine TACE with microwave, we can achieve prolonged survival benefit. Another good point, they have found out that if the bilirubin is more than 1.5 milligram per DL, the prognosis could be little worse than the normal than the cases who have normal bilirubin level. So based on these studies, there is a new Chinese practice guidelines published recently, and they said for the curative purpose, you can do microwave to the tumors which have 5 centimeter diameter. If a tumor in the liver is 5 centimeter, you can cure the cases. If the tumor bigger than 5 centimeter, you can go for palliative microwave ablation. Principle, you can see this is the water molecule. When microwave passes through these molecules, they become excited and they start rotate at billion times per second. This is quite high. And when they come in friction with each other, they produces heat. This heat kills the tumor or tumor cells in that particular area in no time, at a very fast rate and very rapidly with very high temperature. So we can escape heat shrink effect, which actually very important factor for tumor ablation. The heat shrink effect is very low here, and we can successfully kill the big tumors completely. So this is the antenna we use, we introduce into the tumor, you can see it, and this is the generator. The time and the power of the generator can yield a bigger tumor sizes. You can see if we give 90 watt for 7 minutes, we can kill a tumor of 7 centimeter in a single insertion, single session. You can see how it looks. This is the needle track, and that is the tumor, and this is area which is a margin clearance achieved here, and also there you can see. And see, that is the case. This is the CT scan of that female. You can see that hyperdense area. This is the tumor. And we introduced the needle into the tumor and burned that tumor completely. That's what it looks after 3 months. You can see, according to the modified RECIST criteria, you can see the tumor is hypodense. There is the tumor debris, and the periphery, you can see it is hypodense. This is the typical feature of ablated tumors, but there is a nodule which is little denser, and that area is untreated. Somehow it has escaped the microwave because we could not take the needle in this area because it is very close to heart. You can see that. Okay. So this is a good treatment response. She was doing well till 8 months, but after that, and then we add sorafenib with this in this patient, and you can see if we add sorafenib, we can get better survival benefit. Now you can see after 8 months, the tumor recurred. Here, you can see the hyperdense areas. Around the hypodense areas. This is the recurrence, dye has taken up. So the patient went for tests in Rela Institute. You can see the white spots there. This is actually the ablated, this is actually where lipioidal condensed. But 3 months after, you can see the arrows areas. These are the recurrence. The tumor recurred within 3 months after test. And so then we again redid microwave ablation. We completely killed those hyper dense areas with microwave. And you can see there is no uptake of dyes, and total tumor has been killed in 2 places. Okay, very good. So we achieved it without any major complications. So, but now what happened? You can see if this CT scan, this is taken recently, after 2.5 years after the first treatment, there are some small hyperdense areas reappeared with hyperdense border. That could be recurrence. So there is again recurrence. Now what we can do now with this patient? This is your thought. What we can do now? Maybe we can use immunotherapy. We can use further microwave, whatever you think suit for the patient. Thank you very much.
Thank you, sir, for your nice presentation. Now, time for question answer session. Learner audience, you are requested to ask any question if you have to the presenter or. Okay. I would like to request Professor Salimur Rahman Sir, President, Bangladesh Society for Liver Cancer Treatment and Research, for giving valuable opinion.
With due respect to my co-chairperson, Professor Pojesh Kumar Rai, whom I respect like my elder brother, you know, all of you know him. He is actually one of my murubbi bolte paren. He is one of my guardian, and I respect. Not me, my whole family respect him, as he was the physician of my father at the last stage of his illness. And another thing that all the students know, that you as a student of MD always do endoscopy. We sit and you do the endoscopy. But that was not the picture initially. We, after becoming assistant professor, even after associate professor, we are not allowed to touch the endoscope. And actually, I purchased the endoscope my own, and I requested my elder brother, Professor Pojesh Kumar Rai, to gather the knowledge of technique of endoscopy. And he agreed, and I installed the machine in my private chamber in my house, and he taught me how to do the endoscopy. That's why he is my teacher also. And this session is very important, because we have learned all the modalities of treatment from this session, except liver transplantation, which we learned in the previous sessions. And you have learned how to do liver resection, you have learned how to do chemotherapy, systemic therapy, how to do immunotherapy, how to do radiofrequency ablation, how to do microwave. All you have learned from this case report. This was a very fascinating and very interesting topic. I congratulate all the four speakers for their very nice and very informative and very learning session. Thank you all. আপনারা যে কষ্ট করে এতক্ষণ বসে আছেন সেজন্য সবাইকে ধন্যবাদ। এবং আমাদের যে কিটটা আছে, কিটটা আপনাদের এখনই দেওয়া হবে সবাইকে। আপনারা সন্ধ্যায় সবাই আমন্ত্রিত। সন্ধ্যাবেলা কালচারাল অনুষ্ঠান, আমাদের উদ্বোধনী অনুষ্ঠান এবং গালা ডিনার আছে। দয়া করে চেস্ট কার্ড যেটা আছে সেটা নিয়ে আসবেন। এখন যে ব্যাগ দেওয়া হবে সেটা চেস্ট কার্ড পাঞ্চ করে দেওয়া হবে, সেজন্য সবাই ক্ষমা করবেন এই নিয়মগুলির জন্য। সবাইকে ধন্যবাদ দিয়ে আমার টিচার এবং আমার মুরব্বী প্রফেসর পজেশ কুমার রায়কে আমার মাইক হ্যান্ড ওভার করছি ফর হিজ কনক্লুডিং রিমার্কস। থ্যাংক ইউ।
Thank you, Professor Salimur Rahman, for your compliments. I am really grateful. I congratulate again for inviting me to chair this seminar. It is a very good seminar, and I am very happy to be here as co-chair. I congratulate all the four speakers. First speaker was Dr. Pratap, and I know the limitations in Bangladesh of doing surgery on liver, and also the limitations in Sheikh Russell Gastroliver Institute. But within few months, he has done 110 cases. It is an outstanding job in our country. I congratulate him for his excellent job. Next speaker is Dr. Farooq Ahmed, and he has shown the case in a very nice way, and we also learned from him. And also Dr. Fazal Karim, his presentation are also very good. And lastly, Dr. Sarwar, whom I know from his childhood, and now he is one of the pioneer in establishing the non-surgical and non-chemotherapy treatment in Bangladesh. So again, congratulations for him. And lastly, আমি একটু বাংলায় বলতে চাই প্রফেসর মাহবুবের মতো। সেটা হলো আমরা তো 70 দিকে আপনার MBBS করছি। তা আমি যখন ঢাকায় আসি তখন কিন্তু একটা জিনিসের খুব অভাব ছিল, সেটা হলো কমিউনিকেশন টু দি পেশেন্ট। এই জিনিস বলতে কেউ জানতও না এবং এটা চর্চাও ছিল না। আর মানে তখনকার যারা মানে জায়ান্ট প্রফেসর তাদের রুমেও কেউ যাইতে সাহস পাইত না। সুতরাং মানে পেশেন্টের সাথে কমিউনিকেশন ইট ওয়াজ অ্যাবসেন্ট। তা আমার স্যার ছিলেন প্রফেসর আজাদ খান স্যার। স্যার তখন পিএইচডি করে আসছেন লন্ডন থেকে। উনি বললেন যে না, পেশেন্ট কমিউনিকেশন এটা ভেরি ইম্পর্টেন্ট, তোমরা এটা করতে হবে, এবং আমি যেন না শুনি যে কোনো কমিউনিকেশন ছাড়া কোনো পেশেন্ট ডিসচার্জ হয়েছে। তো আমরা লিভার ক্যান্সারকে তখন বলতাম মাহবের মতো, যেটা যে আল্লাহর মাল আল্লাহ নিয়ে যাবে 6 মাসের মধ্যে। তো এটাই ছিল। এবং মানে পরবর্তীতে যখন কোনো লোকের সাথে দেখা হয়েছে, তারা আমাদেরকে বলতো যে স্যার আপনি কেমনে অনুমান করলেন যে আল্লাহর মাল আল্লাহ নিয়ে যাবে 6 মাসের মধ্যে? তখন বইয়ে লেখা ছিল যে 5 years সার্ভাইভাল ওয়াজ। তো টুডে উই আর সিইং মেনি পেশেন্টস who survive more than more than 6 months. So that is the one achievement in our country. তো আমাদের সময় যারা আমরা ডাক্তার ছিলাম, আমাদের এই অ্যাচিভমেন্টটা করতে তো অনেক বছর লেগে গেল। আই থিঙ্ক উইথ দ্য ইয়াং গ্যাস্ট্রোন্টোলজিস্ট অ্যান্ড হেপাটোলজিস্ট who are doing excellent job and new job, I think the duration will be much earlier, so that after a certain time we can say that 5 years survival hepatocellular carcinoma. With these few words, I conclude this session. Thank you very much. Thank you, Professor Salimur Rahman, for inviting me. Thank you very much. Thank you, the audience.
Thank you, sir, for your valuable opinion and for concluding the session. Now, time for tea break. All are requested to join the tea break.